Now let's talk about the contents of the cranium. The Monroe-Kelly doctrine tells us that about 80% of your cranium is made up of brain. 10% is made up of blood, and the other 10% is CSF. In children who have a closed fontanelle, or older children, an increase in one of these means that the other two must make a compensatory decrease. And this is what defines intracranial pressure. The pressure inside the cranium exerted by these three main constituents makes up your ICP. An example here shows a patient with an elevated ICP. As you can tell, the ICP increases with each beat of the heart, as the heart is trying to pump blood up into the brain. Normal pediatric range for ICP is 5 to 15 or 5 to 20. Why wouldn't you want an ICP to be elevated? We'll talk about this a little bit more in person. There are a lot of things that can cause increased ICP. Tumors or other space-occupying lesions can, extra fluid in the brain, such as blood or CSF, or even cerebral edema. And just like with anything in pediatrics, we want to catch early signs, even though they may be subtle. Some clinical manifestations of increased intracranial pressure in the infant are shown here. Typically, you see irritability and restlessness, as well as poor feeding as the first signs. Afterwards, they get a stereotypical high-pitched, sometimes referred to as neuro cry, as well as a tense or bulging fontanelle. Clinical manifestations of increased intracranial pressure in children are different. They may start to complain of a headache or vomiting, particularly first thing in the morning. They may have vision changes, and they decline in their school performance or in their energy levels. This table here lists some early but subtle signs of intracranial pressure elevations in both the infant and the child. As you can see, poor feeding, vomiting, or lethargy and irritability are signs that the nurse should keep in their mind that may be linked to a change in ICP. Late signs of increased intracranial pressure include bradycardia, decreased responses, an alteration in pupil size, a change in your respirations, or decreased consciousness and death. When you assess level of consciousness, keep in mind the following medical terms, which sometimes can be confusing. We can go all the way from full consciousness, which is awake and alert, down to a coma or persistent vegetative state, where we cannot find any response of the brain to outside stimuli. Cushing's triad is another way that you can be on the outlook for increased intracranial pressure. In Cushing's triad, you see systolic hypertension, bradycardia, and irregular respirations. Keep in mind the presence of all three of these is a late sign and typically tells you that the brainstem is about to herniate. Now we'll talk about measurement of ICP. First, we need to discuss the indications for ICP monitoring. And this includes any child with a depressed neurologic status, history of traumatic brain injury, or a deteriorating neurologic condition. There are several different types of ICP monitors. You can insert an intraventricular catheter, a subarachnoid bolt, or even an anterior fontanelle pressure monitor, and of course only in younger children. Pictured here is an intraventricular catheter, which you can see is placed into the brain and down into the ventricles, and then is hooked to an external drainage system that also has a pressure monitor. This is called an EVD, or external ventricular drain. So how do we treat increased intracranial pressure? Early recognition and treatment are very important to reduce mortality and morbidity. Initial emergency management includes establishing an airway, reducing ICP by any means necessary, and treatment of shock so that we're still providing oxygen to the brain. Some medications that we can use include hypertonic saline and mannitol. As we talked about before, cerebral blood flow to the brain is very important, but it is also managed by different influencing factors, and oxygen and carbon dioxide are two of them. That's why airway and ventilation is very important. Hypoxia lasting more than 4 minutes can cause irreversible brain damage. Positioning is also important when you're caring for any patient with increased intracranial pressure. Keep in mind that blood is pumped into the brain, but it also needs to drain out. Therefore, making sure that the patient is draining blood from their brain appropriately is a great way to help reduce ICP. You want to keep the head of bed elevated. You want to avoid neck vein compression, so not turning the head from left to right, but keeping it midline. And also avoid any activities that may increase ICP. This includes having a noisy environment, suctioning, or chest physiotherapy. Careful hydration and early nutrition are also important when you're treating increased intracranial pressure or anything that is wrong with the brain. You don't want to add extra fluid as you want to avoid cerebral edema. But again, anything that's healing in the body needs nutrition. So we'll often start gastric feeds with an NG or NJ tube. There are many different medications that we can use for the patient who has an active brain process, such as antibiotics if we're concerned about infectious processes, corticosteroids for certain instances where we think there's inflammation or edema, sedatives, again, the calmer the patient is, the less they're going to need their brain and the less metabolic strain there is on your brain. Some patients need a ventriculoperitoneal shunt placed. As you can see here, this system includes a catheter that's in the ventricle in the brain and then tunneled subcutaneously down to the peritoneal space where it drains. Often, we leave extra slack at the end of this line so the shunt can grow with the child. However, many children come back and need shunt revisions. Anytime you're taking care of a pediatric patient with a VP shunt, if they have a fever, it's a big deal.